engaged in the past in some of the clinical trial activities in this area, and I think it's a very, very important area of active research that we simply can't give up on but need to move forward with. My disclosures really currently are none, but again, I have researched in this area and received contract grant support as well as money as a paid consultant in a past life. So I'd like to review a few components. Number one, omega-3 fatty acids in the brain. I'm sure a lot of this will just be review for the majority of you, merely by your attendance here. We'll talk about the pathology of Alzheimer's disease and the interactions of omega-3 fatty acids with those pathologic mechanisms. How might omega-3 fatty acids influence Alzheimer's disease? I am going to stay focused on Alzheimer's disease. There are a large number of different degenerative conditions as well as cerebrovascular disease that can impair memory and thinking that omega-3s may be useful for. Nonetheless, Alzheimer's disease is the major cause of dementia in the elderly population, and I'd like to keep the talk focused. We'll briefly touch on some of the retrospective epidemiologic data, some of the animal studies as well, and then focus on three, what I really consider major clinical trials in the field. The European trial that was published in 2004 looking at fish oil, the recently published MIDAS study, I think this just came out in Alzheimer's and Dementia 2 months or so ago, and the ADCS MARTEC collaborative, which I was an investigator on for the ADCS. And then what I think is most interesting, what has all of the data shown us? Because only by looking at the past can we know how to move into the future, and I think that that is the critical area. I think we've kind of hit a slump where we're at. Many researchers are beginning to lose faith in omega-3 fatty acids in the area of dementia, and I really think that we need to renew the enthusiasm for the use of omega-3s in dementia amongst researchers as well as clinicians. So, and I forgot to include as a disclosure, I am a firm believer in the scientific data such that I take omega-3s every day, not for my triglycerides, I take them for brain health. So the background for Alzheimer's disease, this is the leading cause of dementia in the elderly. Almost 6 million people in the United States by recent reports, but we can begin to look as the National Institutes of Health, National Institutes of Aging has begun to revise and is working on current revisions of the definition for Alzheimer's disease. We now have clinical Alzheimer's disease in a dementia category. We also have MCI, mild cognitive impairment of the Alzheimer type. That might represent another as many as 8 to 20 million people in the United States suffering from that kind of preclinical or pre-dementia state of Alzheimer's. And then, of course, the third criteria that's being developed is criteria for preclinical Alzheimer's disease, somebody who is perfectly cognitively normal, who we might be able to detect biologically has the earliest changes of Alzheimer's. This could represent another extremely large population, more than 14 million in the United States. And if we total that all up and look at the population just from an Alzheimer perspective that may benefit from omega-3s, we're really looking at almost 30 million people, purely on the basis of Alzheimer type changes. So I am a practicing clinician as well as a researcher, and I'm well familiar with this. I'm sure that most of you have had your own personal lives touched by Alzheimer's disease. It is an insidious onset, slowly progressive dementia. The typical course is 8 to 10 years before someone will die. This is a fatal disease. Many people don't realize that. I diagnose them with Alzheimer's and we talk about the outcome and they say, "You're kidding me. You mean Alzheimer's is going to take my loved one's life?" And the answer is absolutely. There is no cure currently. We use different scales. We'll touch base on that. I'm not going to go into that further here. The underlying biology of disease is classic. Plaques and tangles, and I have a little description here. Let me see if we have a pointer that works. Not sure which is which. Maybe I don't have a pointer. These little flame-shaped, I'll step away from the podium. Hopefully you can all still hear me. These little triangular flame-shaped inclusions are what we call neurofibrillary tangles, intracellular accumulation of toxic proteins. The large diffuse areas of patchy brown are the amyloid plaques in the brain. Toxic proteins killing nerve cells from the outside. Of course, there's much, much more to the disease process than this. This is what Alzheimer's described over 100 years ago. We know much, much more about the disease. Really, the cause of the memory and thinking problems is not necessarily the accumulation of this pathology. It is the loss of nerve cells, particularly the loss of synapses, the connections between nerve cells that leads to a dementing process. I'm fascinated with this because synapse formation is highly dependent on what we call lipid raft formation, fluid membranes so that we can insert and promote the correct protein configurations that allow one nerve cell to talk to another. If those nerve cells cannot talk, we will develop problems like dementia and, of course, nerve cell death. So I also, as a disclosure, I have to state up front that I'm going to largely focus on DHA as the major omega-3 fatty acid in the brain. That is not to slight the EPA lovers in the group. I believe that EPA may play a very powerful role in brain health for a variety of different reasons. Patients with Alzheimer's have these amyloid plaques. That has led to the major hypothesis, the amyloid cascade hypothesis. As amyloid is deposited in the brain, downstream of that, we're losing nerve cells, we're losing synapses. So we can think about targets, and really one of the prime targets for the majority of the pharmaceutical industry is to target beta amyloid. Let's stop amyloid. That's one target. One of the other targets that's really coming to the rise is neuroprotection, anti-inflammatory properties, reduction of oxidative stress. This is another area where DHA may play an important role. DHA has both anti-amyloid as well as neuroprotectant properties, and let's see how that works. I was fascinated by the brochure and the section for the session that we're in right now. I swear that looks like a sinking ship on the brochure for the GOED conference. Is that a sinking ship? Am I crazy? Well, I do think that there are sinking ships and an appropriate place for this analogy. So we can look at cellular membranes. We can look at membranes that are loaded with saturated fatty acids. And we can see that membrane is going to be markedly stiff. That is a sinking ship. Nerve cells cannot have a membrane that is stiff. It must be fluid. And the introduction of omega-3 fatty acids into that membrane, again, form these fluid lipid rafts, assembly of synaptic proteins that give us a brain that functions like the Starship Enterprise. Clearly not a sinking ship. Neuroprotectant properties of DHA have been well worked out, and I find this fascinating. There's a downstream molecule called neuroprotectin D1. Neuroprotectin D1, when upregulated by omega-3 fatty acids, DHA in particular, will suppress pro-inflammatory proteins, your cytokines, your COX-2 functions as an inhibitor, will also inhibit pro-apoptotic, pro-cell death proteins, BCL2, BCXL, and increase anti-apoptotic or anti-cell death proteins, BAX, BAD, BOLD, caspase-3, and the like. The net effect of this is to maintain nerve cell health. So this is one way that omega-3s work in the brain. It's also been well worked out in experimental studies how omega-3 fatty acids, DHA in particular, may inhibit amyloid formation in the brain. There are two proteins, secretases that we call them, that clips the amyloid precursor protein, forming beta amyloid, the toxic fragment. Omega-3 fatty acids have been shown to facilitate alpha secretase, a good secretase that leads to harmless peptides rather than toxic amyloid. It's also been shown to block gamma secretase cleavage sites, reducing the buildup of toxic amyloid fragments. It reduces the oxidation and dysregulation of gamma secretase as well, again inhibiting the formation of amyloid, and has also been shown to inhibit fibril formation, the development of soluble oligomers and amyloid plaques. So DHA, we all know about this. It is the most abundant fatty acid in the brain, enriched in synaptic fractions of the brain, and I think that that's important. So the rationale, much of this as we were putting together the DHA trial for the Alzheimer's Disease Cooperative Study Group, is based on the epidemiology. We've seen that populations that consume high levels of fish rich in omega-3 fatty acids have a reduced risk for Alzheimer's disease. That can be significant. Animal studies show anti-amyloid properties as well as neuroprotectant effects. We know a lot about omega-3s. They're safe. They cross the blood-brain barrier. This is a tool that we can use for brain health. We've known since the early 1990s that supplying omega-3s will rapidly increase brain levels. And this is a simple graphical depiction. People put on a diet deficient in omega-3s, their brain omega-3 levels drop to a baseline almost non-existent, and those that we supplement will reach a maximum brain saturation in a very short 2 to 3 month period. This is some of the animal data that's led to the current clinical trials, and it's a complex slide, and I'm sorry I can't get my pointer to work here. The bottom line is we have animal models that develop amyloid plaques in the brain. And if we treat those animal models with DHA, we can reduce the formation of amyloid plaques. And I'll just show you that briefly. We can see on the slide untreated animals and treated animals. There's a marked reduction, and that's quantitated here. So the omega-3s are not stopping the amyloid in the brain, but they're significantly reducing the development of that pathology, which presumably is causing nerve cell dysfunction. Fascinating that all seems to occur in the membrane. PSD95 is a very important protein required for one neuron to talk to the next neuron, postsynaptic density protein of 95 kilodalton. A low DH diet, we find almost none of this in the brain. You supplement with a high DHA diet, and you restore PSD95 levels in these animal models of Alzheimer's disease. Our current medications for Alzheimer's are somewhat lacking. We're focused currently following the model from Parkinson's disease of neurotransmitter repletion. So we have cholinesterase inhibitors, 3 of the 4 FDA-approved drugs. These basically are trying to help maintain levels of neurotransmitters while the Alzheimer's disease process is continuing to destroy nerve cells, continuing to lead to progressive dementia. These are not disease-modifying. We also have another agent, memantine, or Namenda, which modulates glutamate, again modulating neurotransmitters, not affecting the underlying disease process. We think, the majority, and I speak for the majority of people in this field, we think that the way to treat Alzheimer's is not to put a Band-Aid on the symptoms of neurotransmitter deficits, but to target the disease itself in a disease-modifying fashion. So we can look at drugs that will affect Alzheimer's disease and what they might do. I'm going to step away from the podium again. I'm sorry for those of you that may have hearing aids and have to dial up and dial down. Bear with me. The yellow line is Alzheimer's disease, untreated. People are going to go down, and they are going to die. Now, we can think about adding an agent for symptomatic benefit. That would be our red line. Maybe we get a little bit of improvement. Fantastic. I can move back to the podium. We don't necessarily have to achieve that goal of complete halting of the Alzheimer's process. We will significantly impact the number of people in the United States with Alzheimer's disease by simply slowing disease progression with a disease-modifying agent. Hence, the entire field has focused on this, the Holy Grail. Nobody cares. Nobody's developing symptomatic medicines anymore. We have good symptomatic medicines. We want to stop the disease. We want that holy grail. Is this cup full of omega-3 or not, is the question.
Yes.
So we'll talk epidemiologic studies across the globe, and I've only listed a few here. My apologies to all the other folks. I wrote an excellent review, what I think is an excellent review, on the use of omega-3s in the brain last year that really is all-inclusive. But studies with thousands of people looking at their consumption of omega-3 fatty acids, they all have a markedly reduced risk of developing Alzheimer's disease. I also find it fascinating that if you look back at those epidemiologic studies with data that's come from our clinical trials, you can see that a large proportion, these epidemiologic studies that have looked at ApoE as a risk factor for Alzheimer's, this is a genetic risk. It's like the chubby gene, right? I got the chubby gene from my mom. Doesn't mean I have to be chubby. There have been times in my life where I have been skinny as a rail, but I'm predisposed to carry a few extra pounds. ApoE works the same way in Alzheimer's disease. It is a motor, it is an engine that drives pathology. If we actually break down the epidemiologic studies that have looked at ApoE status, we can see that ApoE negative patients, patients that do not have that additional motor, that turbocharger on Alzheimer's, really benefit. And as a matter of fact, this is the population that I believe that we should target. So, and I've just listed a few of those studies here. The gold standard, though, we've been fooled in the past, right? We've looked at nonsteroidal anti-inflammatories. We've looked at estrogen because the epidemiologic, the retrospective studies have suggested that they protect against Alzheimer's disease. So the WIMS study of estrogen proved that that was completely wrong, that we cannot supplement with estrogen to prevent dementia, will make it worse. And the trial of nonsteroidal anti-inflammatories as well showed negative outcomes in the treated versus the placebo group. So these are very important lessons. We cannot rely on epidemiologic data. We must go further. We need gold standard, randomized, double-blind, placebo-controlled trials. And that's why I focus on these three large-scale studies that have really met that criteria. So, let me see where I'm at here. So this is the European trial of fish oil supplementation, published a few years ago, I believe, in Archives of Neurology. It was a negative trial. Now, I want you all to be cautious. I designed clinical trials. The burden of that is significant because we can have an agent that works. We could have something that would cure Alzheimer's, and if we develop a crappy, excuse my language, trial, we will miss our primary outcome measure, and that trial will be negative even though the agent works. This is a big problem, the biggest problem, I think. So this was a negative trial, but secondary analysis, and we need to be cautious about secondary analyses. They're not going to give us the answer, but they are going to guide us, and they're going to teach us how to design a correct trial. Benefit was seen only in mild subjects with mini-mental. This is a 0 to 30 scale, greater than 27. So this is wonderful. So maybe once we fill the brain with all of that garbage, all of those toxic amyloid plaques, we can no longer influence it. The damage has been done. Maybe we need to get in there earlier. I think that that's an important lesson. Also, in this study, only 31% of the study participants were ApoE negative. I'm going to get back to that because this is a recurrent theme. We're dealing with a population that has a turbocharged Alzheimer engine. And omega-3s are great, but maybe that turbocharger is a little too powerful. With that being said, the majority of Alzheimer patients are ApoE negative. They are not ApoE positive. I don't know why, but in our clinical trials, the majority of people that sign up are ApoE positive. It's a big problem. The MIDAS study is another one, came out just a few months ago as well. MIDAS study looked at 485 subjects with age-related cognitive decline, not Alzheimer's disease. These are elderly folks who are complaining. I think I have some memory problems, but when you test them, they are perfectly normal. 900 milligrams of DHA versus placebo for 6 months. They use a computerized battery. This trial is under some debate in the field because of an interim analysis that led to an adjustment of the primary outcome measure. We need to take that as a lesson of we need to be extremely stringent when we're doing studies, because people are going to throw out our results if we do not hold ourselves accountable to the highest standards of scientific rigor. So the outcome was the Paired Associates Learning Test from the CANTAB. This is a memory test, and the results were positive in that primary outcome measure. A 7-year, we can look at mean age, so how people do. So we could say, that treated subjects at baseline, they're scored in a range where they were about 73 years old, which is simpatico. Treated for 6 months with omega-3 fatty acids, we could then look at their means reduced to a mean age of 65.6. That is remarkable. If 6 months of being on an omega-3 fatty acid can buy you 7 years of brain health, my God, I wish that it would do it for the rest of my body. Maybe it does, I don't know. Some of you might know. So, as well, the placebo group did reduce from 70.6 to 67%, but a marked reduction. There is some learning curve associated with this, but clearly not to the degree that memory and thinking was influenced in our treated group. Other secondary outcome measures that were significant included a visual recognition memory task, both immediate and delayed. So again, here's some evidence that we don't have to wait for Alzheimer's disease. We can begin to look at the normal aging population who, by virtue of a memory complaint, may be at high risk for Alzheimer's, and certainly are from our studies. So the Alzheimer's Disease Cooperative Study Group is a collaborative group of probably about 60 centers. About 40 of us sit on the steering committee. Designed this trial to look at mild to moderate Alzheimer's disease, and I'm going to take you through these results today. This was a gold standard randomized placebo-controlled trial, DHA versus placebo, mild to moderate Alzheimer's disease. We could care less if they stay on their symptomatic medications, they're Band-Aids for symptoms, because that's not what we're looking for. We're looking for stopping the disease process, modifying disease, and we can see that in the slope of trajectory. Participants were limited to individuals who are not taking fish oil omega-3 supplements or eating a lot of fatty fish, of course, because we want to see that we've influenced that. If somebody's already maxed out, as I showed you before, on their omega-3s, well, super supplementation doesn't seem to do much good. The brain can only take so much. Treated with this DHA versus placebo for 18 months. So we randomized these folks, and this is base demographics. The only thing that came up significant between the placebo and DHA group is percent females. Placebo group was a little bit higher than our DHA. This sometimes happens. The analyses were all adjusted for that gender difference, which is something that absolutely must be done to maintain the rigor. These folks were mean mini-mental of about 20 to 21. That is, in my opinion, a moderate degree of impairment for them in general. So here's what happened. 555 assessed for eligibility. We enrolled 402, excluded a bunch for a variety of different reasons. People come in for these clinical trials. We don't necessarily know upfront how much fish intake they're having on a regular basis. So simply those sorts of exclusionary criteria knock out a large proportion. This was actually the most rapidly enrolling clinical trial in Alzheimer's disease that has ever been done. Full enrollment in this trial was completed in about a 6-month period, which is markedly unusual. The ongoing phase 3 trials in Alzheimer's disease that are ongoing today, and I won't name any names, have had enrollment periods in the range of 2 to 3 years. That's 2 to 3 years to try to drag people into these studies. It shows the attractiveness of this kind of an approach. We have very safe, very healthy intervention to influence Alzheimer's disease. The public wants these studies done. They will help us to do them. That's wonderful. So allocated to DHA versus placebo, we did lose about 28% in the DHA treatment arm, 24% in the placebo arm, but only 6% due to adverse events in the DHA group, this exactly equivalent to placebo, right? So placebo, the sugar pill, causes all sorts of things: dizziness, stomach upset, headaches. You'd be surprised what a sugar pill can do. So we followed these folks, completed 171 folks, 72% of the cohort, 18 months on DHA and 76% on placebo. And then we were able to look at these with an intention to treat analysis. We were able to show from the blood that we drew, here's our placebo group, they maintained their DHA plasma levels, but again, in a very short period of time, we were able to maximize and stabilize their serum levels. And likewise, when we looked at spinal fluid in these cases, and I think this is extremely important for clinical trial design in Alzheimer's, if we're going for disease-modifying agents, we must measure disease. Memory and thinking is still required by the FDA as an outcome measure, but I think that that's going to change, and I think that's going to change soon. So here's CSF levels of DHA at baseline between the placebo and the treated group, and after 18 months of treatment, voila, we've maximized DHA levels in the brain. They have wonderful synapses at this point. But we looked at our memory and thinking test measures, and nothing came up positive for our primary outcome measures or our secondary outcome measures. So the trial is negative, right? And I think that this is important. There can be no doubt about that. We also looked at brain atrophy, shrinkage of the brain over that 18-month period, no difference between the treated and placebo group. But now we get into what I find fascinating. We began to look at the subgroup analysis, again, which are not going to carry the weight of any sort of an indication. They're not going to prove anything one way or another. We are going to use them as data to inform and guide successful future trial designs. People argue about this. In Europe, there were several trials of TPA, the clot-busting drug that people have after strokes. The European trials have all been unanimously negative. So what did we do in the United States? We designed a TPA trial, single trial, that took all the lessons from the European trials into account so that we stacked the odds in our favor, did one trial that proved that TPA worked like gangbusters, and now it's given to everybody who has a stroke if they make it to the hospital in time. That's what secondary analysis does for us. That's incredibly important. So we looked at mini-mentals. Now, granted, mini-mentals in this group, I already told you, were around the 20 to 21 range. So that's what we used as the dividing line. Not like the European Freund-Levy trial that used 27 as a discriminator between those that might benefit or not. We saw no benefit in that subgroup analysis, but again, in my opinion, somebody who's 21 is in the moderate stage of disease. They have significant pathology in their brain. Then we looked at E4 carrier status, and we began to see, again, that emerging theme. So this is our E4 positives, and we can see that treated or untreated, we're following the same line. But we can look at our ApoE4 negative patients and begin to see a statistically significant effect on measures of cognition. We're improving things for our patients that were on omega-3 that are ApoE negative. This is our ADAS-Cog again. CDR sum of boxes, more global, rough measure, didn't show that same effect. Activities of daily living remained relatively the same. The neuropsychiatric inventory I find fascinating. This is the #1 problem for patients and family members with dementia. We were beginning to see some positive effects in our ApoE non-carriers. Brain atrophy rates, again, though, did not reflect this. Adverse events, as I've already talked about, I won't go into this, but certainly my slides, I think, are in your handouts. No significant difference. We have a very, very safe agent that may work in a subpopulation. So conclusions, DHA supplementation did not slow the rate of progression of Alzheimer's disease the way we wanted it to do amongst all comers. Secondary analysis raises the possibility that in the right population, we may be able to show significant benefits. There's the general thinking in the field, treatment too late in the course of disease. This is what we call the slide of the year for 2010. It basically shows that years before somebody might develop memory, thinking, or functional problems way down here, they're already having that buildup of amyloid in the brain and neuronal dysregulation in blue. We need to shift back that paradigm. We need to get people before the brain is destroyed. We can think about DHA benefit in ApoE negative subjects. And again, we begin to see this. There is no known mechanism that we can really justify that in other than to say that we know clearly that ApoE4 carriers develop the disease at an earlier age of onset. Their disease may be more aggressive, and they certainly have higher levels of pathology in the brain when they come to autopsy. So my general take on this is that we need to be smart here. I believe in the omega-3 fatty acids. And I hate to see people toss them out of potential benefit in the area of dementia. I think we need to take into account genomics and what I call environomics and psychomics in the rational use of DHA and EPA for cognitive health. Carriers of the ApoE allele from epidemiologic studies and from our clinical trials are not going to benefit. So why are we going to throw them into our study group? They are going to dilute the primary outcome measure, and we're going to have a negative trial. Let's run the trial on the people that are going to benefit. No one knows who is who. That's true now, but it may change in the future. You know, this ApoE effect is seen in a large number of different compounds that have been tested in Alzheimer's disease. It's not just the omega-3 acids. A turbocharger is hard to overcome. Environomics, people with high E3 consumption certainly may not benefit. But we also need to think as well about our N6 derivatives, other risk factors. We need to pick a population. Now, if somebody's taking fish oil and is out there eating a half pound of bacon a day like we like to do in Kentucky, I don't think they're really going to benefit. I think that their nerve cells are going to be stiff like bacon grease at room temperature. And psychomics, early disease, supplementation, much better than late stage. So let's design a practical trial. Early stage, really early stage, ApoE negative, ideal candidates for omega-3s. Let's make a successful trial. Let's get this approved.